Okay, I'm with Dr. Allan Corder today. He is a retired surgeon who obviously has spent many years working within the healthcare system. I'm going to allow him to fill in the background on his career and the fields that he's worked in. I'll just introduce Dr. Corder firstly, and then we can begin. So, firstly, thank you very much for getting in contact, and thanks for joining us today.
It's a pleasure.
Right. As I mentioned, can you firstly just tell us a little bit about your background, about your specialism, and about your career?
Yeah. Well, I was a consultant general surgeon in a district general hospital, specialising mainly in cancer surgery. Um, I On the way to becoming a consultant, I had quite a lot of exposure to the scientific sides of medicine and surgery, including a BSc in physiology during my medical student days, and then on the course of my career, writing quite a number of scientific papers about surgical topics, but quite general medical topics as well. And then later on, I was asked to become a reviewer for some of the medical journals. So that gave me pretty good insight, both writing scientific papers and also evaluating scientific papers, including the statistical aspects. I'm not an expert statistician by any stretch of the imagination, but I know enough to know what statistical skullduggery looks like, uh, and quite a bit about the ways in which publications are evaluated and used in the medical literature. So I have a bit of background, which is useful, but I'm not a neonatologist, as we have discussed.
Yes, that's absolutely fine. So I received an email from you a while ago, and you expressed your concerns about the Lucy Letby case. So, how did you first become interested in this topic?
Well, the the first I think I ever heard about it was in the general news about her conviction, and I had not been following it at all since then, up till then. The I think when I first heard about it, I my thoughts went to Harold Shipman, to Beverly Allett, these sort of proven cases of medical, um, uh, bad, well, criminal medical practice, and so I didn't really sort of think about it until I started to see quite a lot of stuff coming through. We get a publication called The Week. Um, we don't get a daily newspaper. We get a publication called The Week, and there was a feature about that, about the case in that, expressing concern, and then there was the initial BBC documentary. I think it was a BBC documentary, in the initial one, or I can't remember which channel it was on. And then I began to get more and more interested, and I contacted a chap called Peter Elston, who's a statistician, a fellow of the Royal Statistical Society, and got in contact with Mike Hall through a sort of medical network, and then started to read things like the leave to appeal document, which is in the public domain, the article in the New Yorker, and then took an interest inquiry, the babies who died in the cases, and really that's where I went. Yeah.
Okay. And I know that you've become quite active actually behind the scenes, and that you recently organised an event in Hereford that Professor Michael Hull spoke at. Just a reminder for people, he was the uncalled defence witness. So could you tell us more about that event and perhaps
Well,
sorry.
yes. Well, what happened was that I'm a member of the local medical society, and I asked the members at a meeting whether there was any interest in me putting on a talk, and there was some. So I contacted Mike, and to my pleasure, he said, "Well, yes, I'm happy to come up to you and give a talk in Hereford, which is close to where I live." So and he gave us a good talk. Of course, he is, was there throughout the trial, either in person or virtually, and he knows that he knows the trial probably better than anybody else, really.
Yeah, absolutely. So what were your kind of observations about his talk in Hereford? What was the tone of it?
Well, the tone of it was, to put it very crisply indeed, he didn't think she had a fair trial. He doesn't know really for certain whether she's guilty or innocent, but he didn't think he had a fair trial. And basically, he was saying that there was a lot of stuff which the jury was never told, which should have been disclosed, which wasn't, um, for reasons which are not at all clear. And he still doesn't know why he wasn't called for the defence. He that he's never been told that, and he doesn't know why. I mean, he has a far more measured approach than Dowie Evans,
Yeah.
and maybe the defence thought that he wasn't, vocal enough or something like that. I don't know. That's speculation, but we're not we don't know that. But what he did say, to put it very crisply, is that he felt that there were significant problems with the allegations in many of the baby's cases, that many of the murder cases, and he pointed, and he gave the talk and pointed this out in, yeah.
Yeah, absolutely. Um, so I know that you yourself have many criticisms of the evidence that appeared in court for the
Mm,
numerous case. I mean, really every case, isn't it? But we're going to talk
yeah,
about some of the key cases today.
yeah, yeah,
And we're going to begin by discussing the twins, child A and
yeah.
child B. And I know you have many observations about this, firstly.
Hmm. Yeah.
So if you could
Well,
just,
well, yeah,
sorry.
yeah. First of all, actually, before we get on to that, can I
Okay.
just say about the general business of the statistics in the trial?
Yes.
This is absolutely classical case of selection bias, where you pick the things that suit your that suit your argument and discard the things which don't. What I'll ask people to think about is the following proposition: that if Lucy Letby had not been there at all, she she couldn't have been accused of anything. If she was there all the time, she could be accused of everything. Yeah, if 100% of the time.
Yeah.
The fact of the matter is, she was there quite a lot of the time, so she could be accused statistically of quite a lot of things. I mean, that's easy to understand for a non-statistician, and it encapsulates the issues of the fact that she's been accused of these things anyway. If you do a reductio ad absurdum argument, you know, it becomes clear that what they showed in the trial is entirely inappropriate.
Hmm.
That dreadful chart.
Yeah.
Yeah. Anyway, back onto baby A and B. Um, yes, these were the children of a lady with antiphospholipid syndrome, and antiphospholipid syndrome is a a major cause of pregnancy problems, a major cause of miscarriage in pregnancy, and is a known risk factor for pregnancies. In fact, I think although it's a relatively rare disease, it is one of the commonest causes of miscarriage in pregnancy. So the mother was looked after, I think, at Countess of Chester, um, but I think there were arrangements for her to go to what was described as a specialist centre in London, and for reasons which I'm not clear about, she didn't. Partly because she developed hypertension of pregnancy, which could have been an entirely predicted issue in her case, but it didn't seem that contingencies for that had been made. So anyway, she was treated for hypertension pregnancy in the Countess of Chester, and given as part of the treatment for hypertension a drug called labetalol, which is a beta blocker, which decreases the heart rate and to some extent the blood pressure. It's part of the treatment for this, I understand, and had a cesarean section at which her twins were born. It had to be done early because her hypertension was dangerous at a dangerous level, and so she so she had the I think it was 31 weeks or something. So it was not incredibly premature, but quite premature. The babies were non-identical twins, so it is extremely unlikely that they were monochorionic twins, actually. It is theoretically possible for them to be monochorionic, but it is very unlikely. And Mike Hall does not think that they were monochorionic, or it has no record of that. Anyway, the thing about the antiphospholipid syndrome is that the thing which causes the unusual blood clotting can be transferred from the mother to the babies, and blood tests were done at the Countess of Chester, which indicated that those antibodies had not been transferred to the babies. But anyway, baby A was not well managed. He was without any intravenous fluids for 4 hours. And then there was a bit of what appears to be not very competent interventions from the registrar on duty, who was unable to get various lines in, finally put in a long line, which was judged to be too close to the heart and was taken out. There's quite a lot of detail there. And then apparently 20 minutes after the long line was put in, oxygen levels decreased, and the sort of emergency calls put out, and a consultant did come in at that stage, but up to that time it had all been managed by juniors. And then sadly the baby died, despite efforts for resuscitation. So that was baby A. The At post mortem, the findings were across pulmonary arteries, which in themselves are not necessarily dangerous, but can be associated with other congenital abnormalities, apparently. And the one of the points which has come up, which is important because of the allegations of air embolism, is that a pathologist specifically looked for any evidence of air embolism and found no froth in the heart.
Mm.
I think the pathologist may have looked carefully because of all the issues about the failure of the umbilical venous catheter and other lines going in, and wondered whether there could have been an accidental air embolus. I don't know, but anyway, the pathologist did make a note of that there was no sign of froth in the heart, also, and so no sign of air embolism. That I think it was Dr. Saladi, I think it came.
Mm.
Anyway, so then so we don't really know why that baby died. The expert witness panel thought it might have been the clotting thing, and indeed it might have been the clotting thing. I just asked people to consider that blood tests like the one for antiphospholipid, which is done on the babies, there may be other factors in the mother's blood apart from what they test for, indeed possibly unknown factors. And the antiphospholipid syndrome is not common, and there's not a huge body of literature about it,
Mm.
but there are some good papers, mainly from France, actually, and also meta-analyses, which do show that overall there's about a 4 times increased risk of neonatal death in babies whose mothers have had or mothers have antiphospholipid syndrome and who are successfully born. Obviously, a lot of these babies are sadly lost as miscarriages because of the underlying nature of the antiphospholipid. Um, so, uh, yeah, and then the at the trial, the gas in the large vessels, which was pointed out by Dr. Arthurs. Well, the thing that Dr. Arthur didn't say is that this is not an uncommon finding in babies, neonates that die, sadly. And there are other papers which show that to be the case. And also in the leave to appeal, the leave to appeal said, well, Dr. Arthur said that this was incredibly rare. And then they give a list of things, including sudden infant death syndrome, where it is known to occur. So it's a, it's a sort of again being very selective with the evidence. The other thing that Mike Hall points out about baby A is that the Evans and Bowen said that this baby was entirely stable and she was doing well. And when you look at the respiration chart, it's clearly abnormal, very abnormal. Very few normal readings within that respiration chart. The odd thing about it is the blood pressure chart remains stable, but there's a reason for that. And the reason for that is probably the beta lock, that's beta blocked. So the pulse rate of the baby is not going to go up. So none of this stuff was shown at the trial.
Mm.
The fact that this baby was not stable, that the respiratory rate was gradually increasing and was abnormal. This is not signs of a well baby at all.
Yeah.
So yeah, completely muddy waters. Yeah.
Absolutely. So there's just a couple of follow-up questions I'd like to ask you. The first one is just to clarify something. So I have cited myself the notes about the lack of frothy blood
Yeah.
in the ventricle of the heart. Now, I just want you to confirm that is a critical sign, isn't it?
Well, I think it is because now this is not a well-studied topic, and the literature is clearly there are no experiments done on human babies. That it's sort of that doesn't happen. But the if you are to propose that an air embolus was the cause of death, surely you've got to have, and that it stopped the heart. Okay, being one of the principal definitions of death, you've got to have some evidence that there was something stopping the heart there. But if there isn't, then it surely makes it a tenuous proposition.
Yes, absolutely. The other thing I wanted to ask you as well is that when I spoke to you previously, you cited the fact that there was nothing that when you essentially were critical of the notes, saying.
Yes,
So
yes.
could you expand on that a little bit, please?
Well, as I understand it, there were no contemporary records made of an odd rash at the time. This was all um, people chatting about things, or and obviously making statements in court and this sort of thing. Now, the thing is that sadly, when anybody dies, not just babies, you can get all sorts of strange discolorations as death overtakes them, sadly. And the thing is that there's very little consistency about these descriptions throughout the trial. And throughout what some people talking about some discoloration on one side of the body, some people talking about flitting appearances, other people talking about lines of stuff. It's not a consistent story, and Xu Li himself says that really this isn't anything that convinces him that air embolism was a factor here.
Yes, yes, fair comment. So that's really interesting information on the twins. Um, Child C, for me personally, and I think Mike Hall shares his opinion.
Sorry, can we just go back
Oh
to
yeah,
the twins, because
of course.
baby B also had a
Right.
rocky passage, but she survived, which brings me back to the idea that antiphospholipid syndrome and neonatology are not well researched topics. And indeed, I mean, Mike Hall himself says he's only seen, I think, one or two cases of antiphospholipid in his career, and he's a very experienced neonatologist. So, I mean, I think there are lots of questions about why mothers with antiphospholipid syndrome do produce babies that have an increased risk of mortality and presumably other complications. And I just wonder whether baby B's um, problems were still related to the antiphospholipid, despite the fact she didn't have demonstrable antibodies. So, yeah. Anyway, sorry, on to baby C.
That's absolutely great. We've got to get everything clear. So,
Yeah,
yes, I think for me, Child C is a particularly egregious case in this court case
yeah,
of many egregious cases. Um,
yeah,
I think it's now almost universally accepted by anyone with any qualifications that the prosecution case for this infant is utter rubbish. So
yeah.
could you give me your view on this infant?
Well, the child itself was extremely high risk. And actually, there's a point about risk of these babies, who are all premature, except for baby D. They were all premature. They all had risk factors. And sadly, because of the amount of information that we have, we're not able to calculate the exact risk, because there are two well documented ways of doing this. There's a thing called SNAP and a thing called CRISP, where you can actually feed in data and work out the percentage survival rate of these vulnerable children. But we don't have enough data to fill in the required data boxes to actually get that. But we know that baby C was 30 weeks, so considerably premature, but was only half the weight that you'd expect a 30-weeker to be. It had very, very severe intrauterine growth retardation, had a condition called absent end diastolic flow, where the heart is simply not working well. There were pregnancy issues as well. Baby was delivered early by cesarean section, never opened the bowels, had bowel stage nasogastric aspirate, was extremely small, and Lucy Letby was not working on the unit until 3 days into the baby's care, and 2 days, 48 hours, an X-ray was taken, which showed a significant probability of a bowel obstruction. And somehow at the trial, it got put that Letby had injected a large amount of air into the nasogastric tube of the baby when she wasn't there. But nobody said she wasn't there. I mean, astonishing, really. Yeah. But there we are. And then when this was all kind of, when it all came out finally, which I believe was well after the trial, that that Letby couldn't possibly have introduced air into this baby. Darry Evans then changes his view, or maybe even changed it during the trial, and said, "Oh, no, actually, it's an air embolism instead." Well, I mean, this is absolute nonsense, isn't it? First of all, he alleges air down the nasogastric tube, and then air embolism. And this and all the other babies where air down the nasogastric tube was alleged, or overfeeding, have been absolutely rubbished by anybody who knows anything about medicine at all. If you pump air down the nasogastric tube, it comes back up one way or the other. If you put too much food in, it comes back up one way. It doesn't cause the problems that they are talking about. It just doesn't happen like that.
Yeah.
Anyway, back to baby C. Baby didn't do well. Was never, I don't think, was ever actually off the ventilator. It was a high glucose, and then the baby finally collapsed and did not respond to resuscitation. And the pathologist, the post-mortem, did show significant problems with the heart and the lungs. But for some reason, Dr. Gibbs contested this and this argued with the pathologist, who I think actually stuck to their view. I'm not sure why Dr. Gibbs didn't agree that the baby had significant cardiac problems. I mean, it had significant cardiac problems in utero. So I would have thought that some cardiac ischemia would have been, in other words, shortage of blood supply to the heart muscle, would have been predictable from everything that they knew about the baby. I mean, the other thing is that I don't think, as far as I know, I don't think the baby was actually seen by a consultant. Yeah, not seen by a consultant for 3 days, well, this is a very high risk child. I mean, what were these people doing? Were they asleep at the wheel, or did they have no interest, or what? I don't know. Because I mean, if this had been my patient, I'm not an neonatologist, and I knew that there was a child who had a significant chance of not making it, I'd be looking at it very carefully on a daily basis. I mean, no question about it. But it didn't seem that this was the what you might call the modus operandi of that unit, really,
Mm.
as far as we can tell. I mean,
Well,
I haven't spoken to any of these people. Yeah.
all of the evidence points to that. I mean, obviously, we know infamously about the ward rounds, and
Yeah.
it's clear that they haven't taken the monitoring of the infant seriously enough. I think that's
Yeah.
a fair
Sure.
assertion.
Yeah.
Um, so I want to ask you about the court case with regard to Child C. So essentially, we know that what was said in court is complete rubbish. Um,
Yes.
no one really disputes that now. So um, it's a very obvious bowel obstruction. This was a very unwell infant.
Yeah.
I know Professor Michael Hall believes this. So should he have been called to give evidence, in your opinion, for this case? Could that have helped?
Yes. Yes. I think so. And it's baffling. It's baffling that he wasn't. And I mean, also the it's baffling that the other thing which I've thought it's not only the likes of Professor Hall who expert neonatologist. There's a whole group of pediatric surgeons in children's units around the country who could have been contacted to give, to write a review. Um, these people are people who have operated on premature neonates, and would be able to say, look, this clinical picture was very typical of bowel obstruction. Now, in fact, at post mortem, there wasn't a formal obstruction found, but the sort of bowel that this baby had looked as if it could easily have twisted and caused that clinical picture. So it's I mean, the whole case is just sort of totally, totally porous, really. I think you could say. Yeah.
Yeah, yeah, fair comment. Yeah. So let's move on to child D then.
Yeah.
So when I spoke to you, you cited sepsis, poor care, a delay in administering antibiotics. Could you discuss those issues and anything else of relevance in the case of child D?
Well, I'm not a neonatologist. I'm not an obstetrician. But it seems absolutely clear cut that the hospital's own guidelines were not followed when this woman's waters broke.
Mm.
And she was the mother was, I think, 60 hours before she was between the waters breaking and her delivery, um, which was, I think, a cesarean section, emergency section, because of decreased fetal movement, I believe. So yeah, decreased fetal movement. So and the child was after delivery. The child was never good, um, never really stable. The only thing that I could say, which is significantly against infection, was that the CRP wasn't very raised. But you do see patients with severe infections, sometimes overwhelming infections, that the CRP isn't raised. So I don't think that's a deal breaker. But going back to the fact that she wasn't given antibiotics, the mother wasn't given antibiotics. No, I think that you say, well, is this negligence? Yes, of course it's negligence. It's a serious mistake. But I mean, that's what negligence often is a serious mistake. So
Yeah.
I would have thought that it was fairly cut and dried. Now, I don't know whether, you know, the trust has been sued on this basis, but of course the trouble is that when people are told, no, no, it's your baby's been murdered, they that the trust would be able to say, well, this was entirely beyond our, you can't prove that this was it's been in a court of law. Let's be found guilty. That's the cause of That's the cause of it. So I don't suppose if the mother did sue, I don't suppose she'd win, really.
Well,
If you see what I mean.
at this point in time, I think that's not tenable, but it come in the future. The fact that they've started a criminal prosecution has railroaded any such action, essentially.
Yeah.
But when we, I believe Lucy will be exonerated. I hope it's soon. When that happens, they would have a claim, almost certainly, I would say. But
I would certainly think so. Yes, yes. I mean, I- I'm not a. The other thing I'm not is a lawyer, but yeah. I mean, yeah. To common sense would indicate that they would have a claim. Yes.
yes. I mean, I agree completely. So let's talk about child E. So this is a case where I can't really understand how it can conceivably be in court. Would you like to talk about that case?
Well, again, another high risk baby. All twins have an increased risk, by the way, even if they're term, slightly increased risk. Premature twins do have an increased risk. Interestingly, baby E twinned with baby F, who was the insulin baby, one of the insulin babies. Anyway, um, 29 weeks, so significantly premature, not not too reasonable weight, um, but there had been some problems with the child. I believe there'd been some problems with the child's glucose levels. Uh, yes, had some hyperglycemia, hyper too much glucose in the blood, and then the child collapses with blood around the mouth, and then produces more blood. Basically, has what we call an upper gastrointestinal hemorrhage. And the allegation was that Lucy Letby somehow caused this by instrumenting the esophagus with some sort of sharp weapon, unspecified. But according to Dowie Evans, there's lots of things that could have done it in the neonatal ward. I believe he proposed at one stage that it was a nasogastric tube, and that's a bit like trying to kill somebody with a balloon, beating them over the head with a balloon. I mean, it's just sort of ridiculous. And the defense counsel should have had fun with that. I mean, it's that ridiculous.
Hmm.
Anyway, so the thing is that if you poke something down somebody's throat blindly, you're not necessarily likely to cause them to bleed very much. But the significant problem with that, and that's something we used to see a fair bit in the past in surgery when we used rigid esophagoscopes, was that you could perforate the esophagus, you could perforate and cause. So usually the problem was perforation and sepsis, not bleeding. To actually cause bleeding by doing that is, well, it's just not something that really happens. And the volume of this blood in the end, there was a warning signs with some, and then quite a significant amount of hemorrhage. There was very little, very late blood cross matching, to make up for any blood loss, very little of what you would normally describe as in normal adult or even pediatric practice as proper volume resuscitation. And then when the baby sadly died, um, the the pediatrician said, "Oh," to the mother, "Well, I don't think we really need to do a post-mortem here because it's necrotizing enterocolitis is the diagnosis." Well, there was nothing to really indicate necrotizing enterocolitis as this problem. So we have incompetent advice, and then we have no evidence. I mean, it's no post-mortem. Mother asked to make decision after decision with doctor. I mean, one of the collapses was when Dr. Harkness was actually in the room. So what, she isn't it be supposed to have, what was she supposed to have done when Dr. Harkness was actually in the room? I don't know. I mean, it is extraordinary. The one of the things, the emotional things that have been cited was the mother heard the child crying in a way that she'd never heard a child cry before. But how many times has she had a premature baby? I mean, honestly,
That just has no value. Has no
the
value.
trouble is that's the sort of thing that somebody's going to dredge out to say, "Oh yeah, oh yes, this baby cried because it was assaulted." Well, I think that's an extremely poor conclusion, actually. Yeah. Anyway,
It
yeah.
just, it just,
So,
I
so
mean, it
I,
has no, it
yeah, I
has,
agree with you. It's ridiculous. Yeah.
sorry, it has no value at all as evidence. None. It shouldn't be in the court case.
No,
It,
no,
it would
I
be
think
like
you're right.
it would be like taking you or I to like Cape Canaveral with NASA, and then we watch a space shuttle take off, and then go, "Oh, I've never seen a rocket take off like that before." Yeah, because we've never been to we've never seen one before. We've never been to NASA before, so it
Yeah,
just
yeah, I know.
it doesn't mean anything. It means
Yeah,
absolutely nothing.
no, I know.
Ridiculous. Yes, I
Yeah,
wanted to ask you a couple of follow-up questions.
yeah,
Firstly, I know that you're very critical of the lack of a post-mortem in this
yes,
case. So can you just
yeah.
explain that a little bit more, please?
Well, I think the problem with that is that the lack of the post-mortem was a direct result of the pediatrician's lack of expertise in managing the case. Because I think it was a lady, I think it was a lady, um, said, "Oh, well, we know the diagnosis, so there's no point in doing a post-mortem." Well, the diagnosis was completely wrong. Well, at least there was no evidence to support that diagnosis. And I mean, it's possible that it was the correct diagnosis, but there are other more likely ones. And yeah, so this is again one of these sort of after the event calls. Oh, yes. Oh, Letby was there. Yes, yeah. And of course, we don't really know what happened here. So let's bung it in. Let's bung it in. Let's make an allegation. Yeah.
Hmm.
I think that's the Dowie Evans view.
Yeah. It does seem that way. It does seem that way. Um, is it fair to say the care for child E was negligent?
Um, I think I would be suspicious that it was,
Hmm.
but um, without sort of be able to see the notes and looking at it really carefully.
Yeah.
Um, it, it, the thing is that it, what you and I might regard as negligence is not necessarily what the lawyers regard as negligence or what the courts regard as negligence. It's a difficult one of these things which is difficult. I think I think the standard of care was substandard. No, little doubt about that. And the way that the that the doctor managed the case was substandard because, if for any other reason, that she and the rest of the unit had failed to learn actually what caused the death of that baby.
Yeah.
And that's an important thing, because if you're going to get better at doing things, you've got to know facts. You've got to know, if the baby died of an upper GI hemorrhage, you've got to know that that was the case, because the next time it happens, you need to know what to do and
Yeah.
what the failings were and why, how it could be better next time.
Absolutely.
That's the way things improve. That's the way we don't, yeah,
Yeah. Learn
sure.
learn from your mistakes, as in any field. Um, so we're not going to discuss the insulin cases in great depth.
No,
But I just want to ask you about the lack of testing, the lack of adequate
yeah,
testing that occurred in these
yeah,
cases. And for that
yeah.
matter, the dearth of testing across all of the cases in this court case.
Yeah. Well, yes. What do you mean by the second bit of your question, Chris? That you don't think they
Okay.
had enough blood tests generally, or what?
But let's come back to that. Let's focus on the insulin cases
Yeah,
first. We can revisit that in a
yeah,
second.
yeah.
Let's
Well,
just talk about
well,
the inadequate testing for insulin.
yeah. Okay. Well, with regard to the insulin testing, it I find it extremely difficult to see how, when you get a test result back which says something slightly strange, and then it says at the bottom of your report, this must not be used for forensic purposes because the test is not suitable for it. If you don't either, you don't take any notice of that, in which case you just put the test aside, and the babies did get better, so that's fine. But how you can then use the test, which has been which the lab itself says is not suitable for forensic purposes, in a forensic context, I just don't understand. And I don't understand how either Lucy Letby or her defence counsel, probably the defence counsel, thought that it was a sensible thing to say, we accept this, because there's a cast iron reason for not accepting it, and that is that the lab itself says you shouldn't accept it. So what? I mean, it's crazy. Anyway, I don't know whether you've seen this, but there's somebody has posted a large set of these immunoassay results for C-peptide to insulin ratios, and it's quite clear that one of the babies, not F, the other baby, um, is within the range of what they'd regard as normal for that insulin C peptide. Baby F is an outlier, but there are other significant outliers in that data set. And the other thing is that the allegation is that Hindmarsh and Hindmarsh, I think it was, derived his calculations from not from premature neonates, but from general pediatric data. So it's that again, many strangenesses about this insulin stuff. The other thing that does strike me is that obviously baby E and baby F would have been in the unit at the same time. Baby E was given some insulin, and baby F wasn't, apparently. So the possibility of a medication error, which is entirely different from, medication errors do occur. The possibility of that hadn't been explored at all, as far as I know. So, yeah.
Yeah, absolutely.
But I'm not saying that that's what happened. I'm just saying that in the context of the complexity of these cases, and the possibility of sending an innocent person to prison for life, you ought to be damn sure that your facts are right. That's what I'm saying. And there seems to have been precious little um, precious little effort to get the facts right.
Yes. Yeah. I just want to add a couple of things. Firstly, it's difficult for me to speak about certain aspects of the insulin cases because and the new evidence related to the topics you've been discussing because it's included in documents that have been submitted to the as part of the defence and as part
Yeah,
of Lucy's application to appeal.
yeah,
And I can't discuss that for legal reasons. Similarly, there's lots of experts that are in my book who I can't bring onto the channel for the same reason, basically. In addition to that, I just mentioned quickly that we suspect, we don't know, but we strongly suspect that the third insulin case, which is sometimes referred to as Child Y, was part of this
yeah,
submission that the Crown Prosecution Service have just rejected,
yeah,
which is interesting, of course. But as there's no transparency in anything the police or Crown Prosecution Service do, we don't know for
yeah.
certain. Um,
No.
yeah, so I just wanted to mention those two things briefly. With regards to the dearth of testing overall, um, basically there's numerous things they didn't test for. We know for a fact they should have done certain tests and they didn't. But also, what you see in the court case quite a lot, you may not be aware of this, and it might be a difficult question for you to answer. This might be the first time you've heard this, but there'll be some comment about, oh, this we need to do a test for this, or it was noted that a test for so and so should take place, and then it just kind of drifts away. It just kind of melts away, and you never hear about it again. And it seems very likely that those tests weren't done. The other possibility, of course, is that they were done and it didn't suit the prosecution, so they just didn't talk about them again. But if that was the case, they wouldn't have raised them in the first place, I think. So it's likely that they just didn't test them. So do you have any comments regarding that?
Well, I'm afraid I have a very dim view of the issues around uh, shift working and handovers and individual clinicians' responsibilities in this. And so it wouldn't surprise me if, under the circumstances which we seem to see at the Countess of Chester at that time, that things did go adrift. You know, people said, "Oh, such and such test needs doing." We'll pass it on to the next shift for A, B, and C reasons, and then it doesn't get done. And so, yeah, that's there's also difficulties sometimes of actually getting blood out of very small babies and that sort of thing. So that may be another thing, but then that should be documented. If if an attempt is made to take a test and you can't do it, then that should be documented in the notes. So yeah, so it wouldn't surprise me, put it that way. Yeah.
Right, just excuse me. Right, right. So there's a Kiko got hold of the water bottle. I
Oh,
hope no.
they love that. They
Yeah.
love
Yeah.
that.
Oh, yeah, yeah. You don't need to buy her a toy. You just need to get an empty water bottle.
Yeah.
So I hope that hasn't interrupted your listening pleasure too much when I put this on YouTube. Sorry, Keeks, you can't have that anymore. Um, yeah, so let's move on to the Child G case. So this is
Mhm.
the absurd overfeeding of milk claims that were made. So do you have any comments? This child, I just mentioned briefly, this child's born at just 23 weeks, very unwell. So what do you,
Sorry, which one are we talking about now?
this is Child G, the overfeeding of milk. I mean, I've had
Child
countless.
Child D was the waters broke. Um, was that the allegation that there's overfeeding with milk?
Yeah, I think
Uh,
I think I'm right in saying it's Child G. I'm pretty certain it is.
Hang
I
on,
sometimes
I've
get Child.
got the leave to appeal here.
Yeah,
Child D. Well, it was air embolus actually. that was in the leave to appeal. Child D,
Child G,
Delta, D for Delta.
child G,
Yeah.
child G for golf.
Oh, G.
Yeah,
Sorry,
yeah.
G.
No,
Sorry,
no problem.
my hearing again.
I
Okay.
understand.
Uh,
I understand. Let's say yeah. So just child G is the is
yeah.
I think he did. I think he still mentioned embolism, but in the
Yeah.
in the judicial decision,
So child G, overfeeding with milk. Yes, no, nobody. I think that's generally thought to be nonsense.
yeah,
Because yeah, so it is theoretically possible to overfeed a child with milk. It would come back up. The thing is that it's not. If you put a nasogastric tube down and you pump fluid or air down it, the nasogastric tube does not form a seal at the bottom of the esophagus.
mm,
That's impossible. That just doesn't happen because the body doesn't do that, doesn't clamp around the nasogastric tube. So what happens is that if it's grossly overfed, the stomach will vomit
mm,
and will come back either up the nasogastric tube or around it. Um, there's no way you could cause the I think the allegation was so much milk was put down that it interfered with the breathing process. I mean, this is absolute pie in the sky. You'd have to what you'd have to do if you wanted to do that is you'd have to put a very tight fitting face mask around somebody so that they couldn't so air couldn't escape, and then you'd have to forcibly pump stuff down to, because otherwise, the body just doesn't have. It's not got that you can't seal off the exit from the nasogastric tube. It would just come up the esophagus. It's that's what happens if the nasogastric tube gets blocked. A patient vomits. That can be extremely dangerous because they can inhale their own vomit. That's a totally different scenario, and that's not the allegation here at all.
yeah,
Again, a pediatric surgeon would have been very useful in putting that to bed completely.
yes, absolutely. I mean, I've spoken to so many people about this. Everyone just says it is just completely implausible.
Yeah,
So I mean, I find it incredible it's in the court case, but there you go.
yeah, I
Um,
know, I know.
yeah, it really does beg.
I mean, it's all written down here in the leave to appeal, and when you read through the leave to appeal, you think, what, what
Yes,
these people who have written this do not realise what a lot of what they have written is rubbish
yeah,
because they're lawyers, they're not doctors, they don't know anything about this, and that's how the appeal has been dealt with. It's absolutely disgusting, really.
yeah,
Actually,
yeah,
I mean, whatever Lucy Letby may or may not have done, the process is just so unfit for purpose. It's unbelievable.
mm.
I don't think some of these people are really capable of logical thought, it would appear, sadly. But anyway, there we are.
No, you're absolutely right. I agree completely.
Yeah.
So let's discuss Child K. So
Yeah.
this is another farcical case in this court
Yeah.
with Dr. J.
Yeah.
Ram. And I mean, I know, no one with any understanding of anything takes this seriously. But what are your views on this case?
Well, it's another scandalous issue, with shifting stories from the doctors on the unit, possible lying, um, possible just failure to remember things, which happened a while ago. But a very tiny baby in poor condition, needed ventilating. According to other experts, wrong size of endotracheal tube being used, allegations that Lucy Letby stood by while the child's saturations were dropping, which apparently, according to other neonatal nurses is a perfectly normal thing to do until things reach a particular level. And then, according to JRAM, he just happened to be there because he was suspicious. But according to his emails, which are far more contemporaneous than what he just said, he was called. So, I mean, it's and then the child sadly did die after transfer to a specialist centre, which indicates to me that the child had a very poor outlook anyway. Sadly, I can't remember. I'm just going to have a look at the. So I've actually made quite a lot of notes on all this stuff.
Well, let me tell you something that you may not know. Um,
Yeah.
so in this leaked document, police document, I don't know if you know about that. Dr. Evans doesn't cite child K as being suspicious, so he thinks
All
it's
right.
at all. So this was
Is that
entirely,
right? I
yeah,
didn't know that. No.
yeah, yeah.
Okay.
So this was entirely
Well,
predicated
that
on J-Run.
well that's very interesting, which does sort of uh, clarify that there were no proper criteria drawn up of what was a suspicious case at the beginning. And if you're going to look at these things in any sort of scientific, you have to look, well, what is a suspicious case? What are the criteria? And you have to stick to that, because otherwise your further analysis it's just full of selection bias. I mean, it's just, you pick out what you want, and that appears to have been what happened, really.
Hmm, absolutely.
Yeah. So yeah, I mean, I'm not at all surprised by what you say, and I think it's a very interesting point. Yeah.
Hmm,
Yeah.
absolutely. So let's talk about the triplets in the case.
Yeah.
This is quite a complicated one. So can you walk me through your view on those cases?
Yes. Well, this was again an extremely unusual case, and if you look through all these cases, they are most of them have got extremely unusual features, completely unrelated to anything related to surgical, medical, or nursing care. It's the way the babies were. They're whether they were twins, triplets, whether their mothers had unusual conditions, whether they were very premature, whether they were extremely underweight, whether the mother wasn't given antibiotics when she should have been. All very unusual cases, and that's why I think it's extremely dangerous to have made these allegations without considering how unusual these cases were. And this was a very unusual case. Babies OPQ must be, presumably. Yeah, and they were triplets, naturally conceived triplets, but monochorionic, which is extreme, according to Michael, extremely rare. Between 1 in 60,000 and 1 in 1 million births, we are talking incredible rarity. The mother was told that it would be okay to deliver at the Council of Chester Hospital, but each triplet would have their own designated nurse. Well, the other thing that I think is right, I'm right in saying, is that the mother was given steroids throughout her pregnancy to try to make the pregnancy last as long as possible because of the fact that they were triplets. Anyway, she was delivered by cesarean section. The We don't know anything. I don't know anything about who did the cesarean section. All I know was that the consultant was away at the time. So we don't know whether it was what level, whether it was another consultant, whether it was a junior, whatever. Anyway, the babies were delivered quite rapidly by cesarean section. No notes were made about anything being unusual in the delivery, and babies were apparently in reasonably good shape when they were delivered. The mother describes the cesarean section as being quite extraordinary. Obviously, she didn't have any experience of other cesarean sections, but she said when they made the incision, blood and fluid spurted all. This was at Thirlwall, by the way, which is you do find some interesting things came out at Thirlwall.
Yeah.
Blood and fluid spurted all over the theatres and blah blah blah. That indicates to me, and what she also said about her pregnancy is true, and that is that she felt absolutely like she was going to explode. The pressure in her abdomen had become so great. Anyway, the babies were delivered quickly, which is apparently the right thing to do for monochorionic twins, triplets, because if you don't deliver them quickly, the placental blood supply to the last one gets compromised, if you see what I mean. Because, anyway, so we got a fairly rapid delivery of these children. And going on to the post-mortem, we find that both babies O and P had subcapsular hematomas of the liver. The liver is a fragile organ, and if you get a subcapsular hematoma, or indeed any other kind of hematoma in the liver, it's bad news because it can bleed out into other parts of the abdomen, which is exactly what did happen in baby O's case. Whether it ruptured in baby P's case, I'm not sure because I haven't seen the post-mortem results on that, but it did have a subcapsular hematoma. Anyway, so the the allegation is that somehow Lucy Letby traumatized these babies, used them as a punch bag or something ridiculous like that, which would be very difficult not to observe. I mean, this was all she was on day shifts by then, so there were lots of people around, and the baby didn't do well. Baby O developed a very distended abdomen, and then there were started to have respiratory problems, and then was not resuscitated. Dr. Breary put a needle into the abdomen blindly, which I cannot find a description of this being a valid medical procedure. What it is valid for is for a thing called a pneumoperitoneum, where sometimes you get gas into the abdomen, into the abdominal cavity. Sometimes it's not quite clear where it's come from, and it is valid to needle aspirate that. But in this case, I don't I can't see anything which says that was a valid thing to do. Then there's the issue of whether he might have traumatized the liver by doing this. Anyway, the baby died sadly, and then Dr. Marnarides said that it must have been severe trauma that caused this, and the only way he could, as the child hadn't been involved in a road traffic accident, the only way he could see was the inflicted trauma. And my feelings are that these subcapsular hematomas were the result of the triplet pregnancy. You are not going to get a series of 1 in a million cases to say that this happens rarely or often, or see what I mean. It's just on the edges of what is possible to describe in medical literature, and so I think that these babies got their hematomas as a result of the delivery, result of the pregnancy, results perhaps of the steroids, which we know cause problems with, bruising and bleeding anyway. So now, Mike Hall does say that this has not been described in medical literature. The subcapsular hematomas related to traumatic births have been related to traumatic vaginal deliveries, but I think that we're talking about something which is rare, and we've got to sort of think about the probabilities of what did actually happen here. And my money would be on. I would go with Dr. Modi, the pediatrician in the expert panel, who basically says this, that she thinks it's a related to birth trauma, delivery trauma, etc., etc. But yeah, so and then resuscitation. Well, difficult to say really. The prognosis, however well resuscitated, of ruptured subcapsular hematomas in premature neonates is very poor. So whatever they did, may not have been possible to save the child. Sadly, um, baby P was a bit more complicated because it had a pneumothorax, and I think, and I, I'm not, I'm not so well up on the clinical course of baby P, actually. It's but again, I definitely know that child also had a subcapsular hematoma, and the other baby was transferred to Arrow Park or Liverpool Women's Hospital and survived, which is for which we must be thankful. But it sounds to me like this was a very, very, very unusual case. And again, why was it at the Countess of Chester? Why why wasn't this child, why wasn't this mother and baby in a proper tertiary center? I mean, it's baffling, really. I mean, there may not have been beds, and sadly, I had personal experience of patients who needed to go to intensive care units and things, and couldn't find a bed for them. I mean, that was, I'm afraid, the shortcomings of the health service.
Well, one of these babies was born in a toilet, wasn't it? I don't know if that's due to
One of them
lack of beds,
was, but
but
I can't remember. I can't remember which one it was.
no,
Yeah, yeah,
no.
yeah, yeah.
Um, so that kind of leads me neatly to my next question. Obviously, you've indicated this infant should not have been at the Council of Chester. Is it fair to say that several of these infants should have been born on tertiary units?
Yeah, I think so. Yes, I mean, I'm, as we emphasised, I'm not a neonatologist, but my feeling, I mean, if this was, my grandchild or something like that, I would be asking very serious questions about, being about the antiphospholipid babies being on uh, the triplets. I mean, we're now talking that's actually quite a number of the cases anyway. Um, and then the twin pregnancies, the premature twins, baby K. They all should. I mean, they all should have been looked after by people who had a special interest in these very tiny, vulnerable babies. And I mean, the other, there is a very rough rule of thumb about survival of these premature neonates, and that is that if they're born at 25 weeks, they have a 50% chance of survival, 26 weeks, a 60%, 27 weeks, a 70%, 28 weeks, 80% chance of survival, beyond neonatal age. But remember, these figures are all derived from specialist units that specialize in this sort of thing and specialize in keeping their data and knowing exactly what's happened to their patients and all that sort of thing. So we can pretty well assume that in the average level 2 unit, things are not going to be that good, if you see what I mean.
Yeah.
Yeah, so basically there were a lot of very vulnerable babies. I think everybody would people. I think everybody would agree with that.
Mm.
And yeah, so and proportion. I think it's pretty well universally agreed that there's a proportion of premature infants who die. Um, Not a high proportion, but a significant proportion. It isn't possible to find out at post-mortem exactly why they did.
Mm.
And this isn't, this is so, none of this stuff seems to have been discussed really.
Yeah, yeah, absolutely. Can I just mention that you gave a very thorough answer to that question, but even within the kind of litany of vulnerable infants you just described, there's still a 23 weeker in addition to that. There's the most premature
Yeah,
infant. There's I think there was
yeah,
another infant outside of that tranche that's
yeah,
500 grams.
yeah,
Child
yeah,
C, we know, is very vulnerable. So,
yeah,
so
yeah, sure.
it was a
No,
very challenging acuity, wasn't it?
yeah, yeah. And the I think I'm right in saying that when the Countess of Chester looked into the increased number of deaths, they did a sort of acuity calculation, which didn't show a great difference between the preceding year. But the thing is that if you are going to, what you've got to do in that is you've got to factor in the fact that you may have some very extraordinary cases just by chance in your cohort in one year or the other. And that 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 acuity can get buried in the mass of other data,
Hmm.
the massive normal births, normal deliveries, unless you're actually going to look very carefully to whether you had any similar cases to this in previous years, you're not going to discover a lot by doing, that sort of very rough and ready average of acuity calculations, which I think is what they did actually. So,
Yeah,
yeah,
fair comment. Yeah. Um, in addition, in addition to what we've already discussed, what do you think about all of these very vulnerable infants being transferred all over the place? For example, Child I, very vulnerable infant, was transferred five
yeah,
times between Chester, Liverpool Women's
yeah.
Hospital, Narrow Park. So what do you think about that?
Well, I clearly it's very suboptimal, but from not just from the point of view of the transfer, but from the point of view of the continuity of care. Because if you have somebody who is at the helm and looking at somebody on a daily basis, and they are much more likely to say, look, this child is going in the right direction, this child isn't, than somebody who is handing over a perpetual series of handing over, um, where basically it's called clinical experience, Chris. It's when you look at somebody and you think they look a lot worse than yesterday,
Hmm.
or they look a lot better than yesterday. And that's not the whole thing. You do other things as well, but that is something which is very difficult to capture in a situation where people are being moved about all the time. And you know, I couldn't agree more that it's extremely suboptimal.
Hmm.
Um, yeah, yeah,
Yeah, absolutely. So we touched upon the lack of ward rounds on the unit, which has become, I think, almost infamous in this case now.
yeah,
It is obviously we know that shouldn't happen.
mm,
And what you may not know is that when the Care Quality Commission examined the unit in 2016, there's a full report. You can still read the full report of the Council of Chester
mhm,
online. Other units at the hospital were doing a normal level of ward rounds that would be expected in
mhm,
areas that are less critical than the
yeah,
neonatal units.
yeah,
So,
yeah.
so can there be any possible reasonable explanation or excuse for their lack of ward rounds?
It's a bit difficult for me to comment because it's a sort of thing which is internal organization really. But um, if I was let's say, the clinical director, which is a job which I've done on my own unit, and which they would have had. One of the consultants would have been a clinical director, supposed to be, looking at the way the unit was run and all that sort of thing. I would be saying that the neonatal intensive care unit is by definition the place where the intensive care needs to be given. And in order to give intensive care, you need continuity of care. And that means you need continuity of people coming in and seeing the children, or doing a ward round every day. And tries, I mean, and that should be the same person every day for a number of days. So in my view, what they should have done is they should have a rota in which the consultant A does a ward round, a daily ward round for a week, and then consultant B does a daily ward round for a week. And this sometimes means that you don't actually stick to your hours of work completely. So I mean, surgeons are fairly notorious for starting early because they need to get their ward rounds done before they're going to the operating theatre. So, my habit was always to start at 8 o'clock in the morning, do my ward round, which would have included seeing anybody in intensive care, especially seeing anybody in intensive care who was under my care, and then going off and doing whatever else I needed to do for the rest of the day. And that's the way I organise my work, and that's the way all my colleagues organise their work. Now, I don't really see why this paediatric unit shouldn't have done the same myself. That would be my feeling. And if I was a parent or I would want to see some evidence of continuity at a senior level, not handover from junior to junior. No, no, not at all.
I mean, ultimately, they are responsible. The senior people are responsible for the unit, aren't they? So
Sure.
they should be centrally involved. I mean, stands to
Yeah,
reason.
yeah, yeah, yeah.
Um,
No, I think it's, one of the things that I learned from medical school was an extremely good professor of surgery who gave us a talk and said, never forget that you are in a position of great privilege. And that is absolutely true. As a doctor, you hear people tell you things that nobody else will, that they won't tell anybody else. You will see things that nobody else sees, and you have to behave in a way which shows you are in a position of privilege. It's a very good job, and it's a very interesting job, and people's lives are, to some extent in your hands. It's not always possible to save them, but you should be doing everything you possibly can to. So
yes,
yeah,
yeah. Um, interesting perspective. Um, so when I spoke to you last, you also cited the perhaps limited experience of how and why babies die that was present on this unit, and
yeah.
you cited that as being significant. So can you discuss that as well, please?
Well, I'm just thinking that this was a unit where they were boasting. I say boasting in not in a particularly pejorative way, but boasting 1 to 3 deaths a year. And so I'm thinking, what was the individual experience of the 7 consultants, I think it was, on the unit? So if you divvy that out, they're going to be less than 1 death a year between each of them. Yeah. And so how many babies do they see die? And how much do they observe them dying? How much, the, do any of them get strange rashes or strange skin discolorations or anything like that. They're not going to have built up a detailed memory bank of this. And when you look at the contemporaneous discussions, there's not. This isn't a sort of coherent story. They see these deaths happening. The analysis of the deaths is pretty shallow, and then somebody lights on the fact that Lucy Letby was there for some of them, and the story then takes on a life of its own, I think. So yeah, I mean, yeah, and the other thing about this crazy way the court case was conducted was that, I think that on the balance of probabilities that Lucy Letby is innocent, but just say for a moment that she isn't. What a stupid process it is to raise so many doubts.
Mm.
I mean, it goes far beyond the Letby case. It goes on around the whole criminal justice system, doesn't it? But no, I mean, I think I think that Lucy is probably innocent, and that's the view I take, having sort of tried to look at it at all as many angles as I can, but I don't have all the information. That is true. I'd love to be I'd love to be involved and have all the notes and
Yeah, but I
form
think
a detailed,
no, but I think
because
you've got
it's incredibly complex, because it's not only the medical notes, it's the nursing notes, it's all the computer records, it's all the lab results, it's everything, and the whole results from the whole of the unit to get a fair statistical analysis of what the chance of being associated with these cases is. And you say Professor O'Quigley's got some new
mm,
analysis. Is that right?
yeah, yeah,
Yeah,
that's
be
correct. Yeah,
interested to see that.
yeah, I'll send it to you. He's had something published recently, so um, I think he's always a like knowing him to some extent. I know he's always kind of aware that mathematics is complicated, so I think he always try. He has to. You have to do statistical papers in a certain way, but then he tries to make them. Tries to explain them as well. Hopefully, he'll come on the channel soon.
Yeah, yeah.
But he has yeah, he's published something recently, so that's good news,
Hmm.
obviously. I think with regard to what you've raised about the kind of complexity, that's one of the challenges that we have, those of us that believe that Lucy is innocent and believe this is a miscarriage of justice, is that, for example, in the case of the Birmingham Six, it just falls apart because it's very easy to demonstrate, well, actually, there were nothing to do with anything that happened.
Mm,
In the case of Andrew Malkinson, he just simply wasn't at the crime scene.
mm,
In this case, you've got to go through these 17 infants with, immensely complex 10 months of,
mm,
and obviously, when you've done the kind of work that we have and other people have, you look at all the constituent parts of it, and all of the constituent parts of it are rubbish. They just,
mm,
upon scrutiny, they fall apart.
mm,
But you
mm,
still have to demonstrate all that to someone else that may know
mm,
nothing,
mm,
and that's the
mm, mm,
challenge, I think.
mm, mm. Yeah,
Yeah.
yeah.
So let's discuss Datix because you had some pretty strong views on the attitude to the compilation of Datix on the
Mm,
unit.
mm, mm,
So let's
mm.
tell me about that.
Well, all I can really say is that I think it was at Thirlwall, Dr. Gibbs testified that there was no actual policy about who should fill in the Datix forms. And I think, that's a quote. So I think that said it all, really. If you've got a a program or an instrument for looking at your complications or adverse events, and there's nobody tasked with actually filling it in, it's nobody's responsibility to fill it in, well, it's not going to get done properly, is it? So, yeah, I think it's as simple as that, really. I think
Yeah,
it's not, it's a, you shouldn't accept something if it's so full of flaws that you don't think you could do it. You should tell people, but it doesn't seem that that was the case. They just, it seems that nobody, and that's probably because the babies that died were no individual's responsibility.
Mm.
Probably, I don't know whether that's the case, but whether it was just happened to be the consultant who was called in at the terminal event, I don't know. I don't know what their system was, but according to Dr. Gibbs, there wasn't a system. So, yeah.
Yeah. So on a kind of side issue, we know that Lucy's Datix practice was very good. The nurses said this. Numerous
Yeah.
people said this on the unit. So something that is often suggested to me is that, well, I know for a fact, because I've heard so many doctors say this, that consultants sometimes don't like to be picked up by Datix entries. So something that has been said to me is that could the consultants on the unit have looked unfavorably on Lucy because she datexed errors that they'd made or things that the units were doing wrong, and they didn't like this very much? Do you think that's feasible?
I think I think it's possible, but I don't think it's necessarily likely. I think it's much more likely that they just let it go over their heads. Actually, personally, if I had somebody, on my unit who was recording accurately what was going right and what was going wrong, I'd have been absolutely delighted because it would, the thing is that, as we discussed, you learn from mistakes. Everybody makes a mistake at some time or other. It's not, we are human.
Mm.
We try our best, and if you've got an instrument which is going to tell you that there's been a problem, then yeah, I would personally welcome it with open arms. But I suspect that there are doctors who don't like it being pointed out where they may have gone wrong. I suspect that's human nature. But yeah, I don't think it's likely that they said, oh, she's just filling these forms, and we don't like being looked at. I
Mm.
think it's more likely that it's kind of just belle indifference.
Mm. Yeah,
Yeah.
yeah, that's fair. That's fair. I mean, we've discussed this a lot on the channel, so I just like to ask everyone what they think about it, just out of interest. Um,
Yeah.
so I want to discuss the way that Lucy was treated on the unit because I know you believe there was a lack of transparency with action being taken behind Lucy's back. So could you expand on that, please?
Mm. Well, I think that if you have a if you have an issue with somebody, whatever it is, you have a duty to explore it,
Mm.
and I think that talking to the person is the right way to do it. So not just saying to their line manager, "Oh, I think I'm dissatisfied with the way somebody works," or something like that. I think you've got to be engaged in the process, and before you start accusing somebody of murder, I think you need to have had a chat with them about what exactly went on, and what their version of events is.
Mm.
I mean, this if only to get some idea of their reaction to what you say. I mean, it would seem to me to be common sense, and no doubt this is why she won her grievance procedure, because quite rightly it was not treated in a straightforward way. It was sort of all kind of cloak and dagger stuff, wasn't it?
Yes, absolutely. So I want to talk about her grievance procedure. I think this is a very important part of the story. Um, and what I want to ask you firstly is how unusual would it be for any nurse to enter into a grievance procedure against consultants and then win on every point?
Well, Chris, I'm afraid I can't answer that because
Okay.
I have absolutely no experience of it.
Right.
I
Okay.
I have no experience of any nurse that in any hospital that I worked at, and I've worked in very many different hospitals before I became a consultant, of having any sort of grievance procedure, particularly any sort of grievance procedures that involved me.
Mm.
And if a nurse was unhappy with something I did or said, then I would expect her to say something to me about it, and we'd have a chat about it. Um, no, so I really can't comment. I think you'd have to ask the Royal College of Nursing about what the figures were on that. I don't know.
Yeah. We can presume it's rare, though, can't we? Is that a fair presumption?
I would think it is extremely rare. Yes, I
Yeah.
think it's extremely rare, and I think it fits into a pattern of behaviour of the consultants on that unit. I think.
Yes.
I mean, it doesn't sort of jar with me that was the findings. And then the other thing to say about the grievance procedure is that I don't think it was actually, correct me if I'm wrong, Lucy Letby's idea. I think it was the union rep who said, "Look, you've got grounds for a grievance here." So she may not even have done that.
Mm.
I suspect maybe she wasn't. From what else I've read about her, she didn't appear to be a very combative type, and
Mm.
probably wouldn't have even done that. I don't know. I don't know. Getting a
Mm.
bit speculative.
Yeah, no, but I mean, I think it's a fair comment. Um, so in terms of being speculative, I believe that after that grievance procedure, if Lucy had gone for constructive dismissal, she would have won, and we never would have heard any more about this. Do you think that's likely?
I think that's entirely possible. I think that's entirely possible because I don't think that the police would have. I don't think the police would have taken any more interest. I don't think that, from what I can, this again, I'm all only know the bits that I know, which is not by all means everything. But I don't think I think the police were struggling even when they took it on board to put a case. And my feeling is it's only when Dowie Evans pitches up after his 3 hour drive up from South Wales and says after 10 minutes, "Oh, she's been murdering people." Well, that's what the police wanted to hear. They want to say a doctor is telling us that this child has been murdered. So we've got something to go on now. I mean, fair enough. That's the police's job, isn't it? I mean, they don't know whether. I mean, I don't know whether they checked up on Dowie Evans at all. Seems to be plenty of adverse publicity come out since, but yeah, yeah. So I think to be honest, I think you're right. I think if the grievance procedure, if she'd had constructive dismissal, it would have all gone away. And if um and once the consultant tried to interest the police in the thing, until Dowie Evans got involved, I don't think it was going to go anywhere. And then there's also this lady Stephanie Davis who's basically saying, well, actually, it wasn't going anywhere until somebody decided it was, for not very good reasons.
Yeah,
Yeah.
yeah, absolutely. So I just got a couple more questions for you. The
Yeah.
first one is that you mentioned to me that you'd watched my interview with Professor Jane Hutton, obviously a key figure
Yes.
in this.
Yes.
Could I ask for your view on the Crown Prosecution Service effectively excluding her from the investigation?
Well, I think the only reason they excluded her from the investigation is because they didn't think it was going to help them. And that's very sad. It's very sad. It shows that they don't really understand what the importance of statistical analysis. And I believe a policeman went up to Dr. Hutton and saying, Professor Hutton saying, "Oh, what's the chance of this? What's the chance of this happening by chance?" a completely unanswerable question,
Mm.
and shows that he didn't have any idea about how a proper statistical analysis would go. And Jane Hutton, I believe, did say to the CPS, look, this is going to need a big analysis. I'm going to need lots of data, which is absolutely right, because she needed to look at the performance of the whole unit. She needed to look at the possible involvement of other nurses in other deaths, way outside what the police had been looking at. And clearly, that was going to be a big investigation. So it appears that the Crown Prosecution Service has it in their power, which why I don't know, just to say, oh no, we don't want that. We don't want a proper investigation because it's going to be too costly. It's not going to suit us. Well, I mean, oh dear, oh dear, oh dear.
Tragic, isn't
I'm
it?
just going to press the OK button about our it says this meeting is being recorded, and I've just noticed it says OK, so I'm going to say
Oh,
OK. How
yeah,
about that?
yeah. Don't worry.
I can see my face better now. Yeah.
Yeah, yeah. I have been recording for quite a while, so I'm glad you've.
Yeah, I know. No, I was just looking. You see, we people in our 70s,
Yeah,
we look at a particular bit on a computer screen, and when this black line came across, I didn't realise it said OK at the end. But
yeah,
there
yeah.
we are.
Don't worry. I mean, you. I do sympathize with people that didn't grow up with computers who now live in a world in which they're
Yeah,
just ubiquitous.
absolutely.
I mean, I've told this story before, I think probably, but I went to Canada a couple of years ago, and I just reflect on the fact my grandparents would never be able to get through an airport now. I mean, it was hard enough for me. They just make it so everything's like, I'll scan this, go over here. I mean,
Yeah,
I got held
yeah.
up in customs on the way there and the way back because the scanner didn't work. So I'm there at the customs desk going. And they're saying to me, why are you coming back? Because I live here. I haven't got anywhere else to go. The only reason I'm in this queue is because the machine wouldn't scan my passport. Will you let me back into the country? Otherwise, I'm homeless. No. And that's
Yeah, yeah,
my
yeah,
grandparents would
yeah,
have no chance. No chance.
yeah,
It's just
yeah.
insane. Anyway, the last question I want to ask you is I know you had some comments and some views on remarks that were made by Lady Thirlwell at the beginning of the Thirlwell
Oh,
inquiry.
yeah,
Uh,
yeah, yeah, yeah.
please do share
Mm,
that. Yeah,
yeah. Well, yeah. Right at the beginning of the Thirlwell inquiry, Lady Thirlwell said that a word to the effect that she thought that that people much more eminent than myself were making a terrific fuss, and they didn't know what they were talking about, and it was a load of noise, etc., etc. And I was sort of mildly infuriated by this, actually, and I thought, well, Lady Thirlwell, what do you know about? What do you know about neonatal medicine? What do you know about the vulnerability of babies? What do you know about this, and what do you know about that? And the answer is, frankly, sweet FA, isn't it? Really. So I thought this was immensely arrogant, unnecessary, and very interesting to me. The only enlightenment that has come out of the Thirlwell inquiry is actually stuff which really supports Lucy Letby's case.
Mm.
You know, descriptions of bad care, and even I was interested. David Spiegelhalter, the Sir David Spiegelhalter, very non-committal on the statistics of the case. I don't know whether you noticed this. He said, yeah, there were a lot of deaths. Yeah, and they should have been looked into. Yeah, that's all he said, I think.
Yes.
I don't think he said anything else. And I interpret this as, yeah, actually, what you're saying is that the whole thing is statistically flawed,
Mm.
and there should be much better methods of sorting this stuff out than
Mm.
have been used here. So, yeah, so there we are. But yes, there was lots of detail about the way our patients were treated,
Mm.
and repeat of some of the allegations, like the terrible scream and all that sort of stuff. But all the light that was shone was actually um, that it was quite a lot of stuff which didn't support Lucy Letby's conviction, in my
Absolutely.
view. So I'll be very interested to see what the final report says, because
Yeah.
whether any of that will be redacted, as they like to say, I don't know.
Well,
Yeah.
I was discussing this recently, and we came to the conclusion that how could they write the final report and do the recommendations and then say, oh, everything in the hospital was fine? I mean, I just don't see any way they could possibly do that.
No, I don't think they will. I mean, and if they do, I think there would should be a bit of an outcry, really. And I mean, I would suspect that one of the most prominent outcriers would be Sir David Davis, probably,
Yeah, I would think so.
because I mean that's a matter of general public concern, isn't it? And also a lot of money spent on this process, and so it becomes a sort of matter of you know public money, public confidence, etc., etc.
Yeah, absolutely. Agree completely. So that's absolutely great. Thank you so much for joining us today and sharing your expertise and your knowledge and your experience. It's very much appreciated. Thank you for getting in touch in the first place as well. And I'm sure that people are going to enjoy this interview, and we'll keep in touch, and maybe I'll have you on again in the future.
Yeah, thanks, Chris, and thank you very much for all your efforts in this. I think your other interviews have been very good, very fair, and very interesting. So thank you for that.
Thank you. Yeah, no problem at all. And I'll speak to you again soon.